Time now for closing remarks. Dr. Forfia will go first.
So now, counselors, you may make your closing arguments. We'll start with Dr. Forfia.
Thank you, Your Honor. CTEPH is a serious disease requiring surgical and potentially medical intervention to lower the risk of ongoing symptoms or even death. Many CTEPH patients also suffer from residual pH despite an endarterectomy or despite a balloon pulmonary angioplasty. These patients may benefit not only from medical pretreatment in advance of an endarterectomy or a balloon pulmonary angioplasty, but also medical therapy after these interventions. While riociguat has been approved for and is effective for treating post-pulmonary thromboendarterectomy PH, maybe additional patients following either surgical intervention or balloon pulmonary angioplasty could benefit from this therapy and other therapies.
Thank you, Dr. Krasuski. Your closing argument.
Thank you, Your Honor. CTEPH is indeed a serious disease, but the gold standard treatment for it is pulmonary endarterectomy or possibly balloon pulmonary angioplasty, which have both shown marked improvement in patient morbidity and mortality. The evidence to support a broader use of pharmacologic interventions to treat PH in these patients, particularly after intervention, has been sparse. As we talked about, there are two groups of patients we've been discussing today. One are the folks who are inoperable. I think the data is conclusive that those patients should be treated. The data, however, talking about the post-PTE or post-BPA patients, I think is still limited and still up to debate. Riociguat is the only drug indicated at this point to treat CTEPH patients who are not eligible for PTE or patients who have residual after thromboendarterectomy. And these are the guidelines only support the use of this particular drug for that purpose and not any of the others. There is no evidence at this point that treating after BPA is beneficial. And I think that pretreatment, which Dr. Forfia alluded to, was not even in the discussion today, but the benefit in terms of that, I think, is very much in debate, and it's possible that pretreatment of these patients may potentially be harmful.
Thank you, counselors, for your compelling cases. I think to summarize, there's no question that pulmonary thromboendarterectomy is the recommended treatment and the gold standard for patients with CTEPH. BPA may be an alternative intervention. There's also, as you mentioned, only one approved therapy for patients who have inoperable CTEPH or who have persistent pulmonary hypertension or recurrent pulmonary hypertension after endarterectomy, and that's riociguat. As we've heard, other therapies have been considered and are sometimes used to treat some of these patients in an off-label fashion who have persistent pH following one of those interventions. And there are small studies showing or suggesting a benefit with some of these medications. Despite that, we don't have a recommendation regarding the use of other pH therapies for treating patients with persistent pH, and studies are ongoing. So I'd like to thank the witnesses and the counselors for their arguments, and thank you to the jury, for participating.
That concludes this case in holding court in PH. We thank you for your time, participation, and interest in helping PH patients.